Risk Adjustment Clinical Documentation Specificity, Session 5. Today we'll be talking about COPD, chronic obstructive pulmonary disease. We'll look at the diagnosis specificity needed to assign the appropriate diagnosis code, and the clinical documentation required to support the ICD-10 code submitted on your claim. The goal for today's content is to obtain a high-level understanding of risk adjustment specific to COPD. We will be utilizing the CMS HCC Medicare Risk Adjustment Model. The information being shared today is in accordance with the ICD-10 coding guidelines, CMS Risk Adjustment Data Validation Guidelines, the American Hospital Association coding clinics, as well as industry best practice suggestions for risk adjustment success. We hope that you learned one thing that you didn't know or that wasn't clear about risk adjustment, clinical documentation, and/or ICD-10 HCC coding specific to COPD. And we also hope to ease the burden of the day-to-day documentation requirements by helping you understand implementing small changes to get credit for the work you're already doing. For best practice and clinical documentation specificity, specific to risk adjustment data validation audits, it's the one standalone progress note. It is not the medical record in its entirety that's used in a risk adjustment data validation audit. It's the one data service and that one single progress note that is used to validate the ICD-10 code submitted on your claim for that same data service. Does the clinical documentation in your progress note meet the CMS MEET criteria to support the diagnosis codes in your assessment and assign on your claim for submission? Remember that acronym meaning monitor, evaluate, address, treat. Here we're going to talk about the diagnosis of COPD, chronic obstructive pulmonary disorder. Here you have the respiratory conditions for the CMS HCC model for risk adjustment. There are 179 ICD-10 codes for respiratory conditions that are categorized into 8 HCCs. The 8 HCCs are arranged into 3 hierarchies. Only the highest HCC in each hierarchy impacts the patient's risk score, and there is a disease interaction coefficient for patients that have COPD and congestive heart failure, as well as COPD and cardiorespiratory failure. Here's a quick visual of the respiratory conditions in the CMS HCC model broken down. Within each hierarchy, only the highest severity or lowest HCC number impacts the patient's risk score, even if multiple conditions are present. You see in the blue box here on the left, you have HCC 84, 83, and 82. There are multiple diagnoses that fall into these HCC categories, such as respiratory failure and shock, respiratory arrest, or respiratory dependence. You also see the orange box on the right where you have HCC 112, 111, and 110, and those are for multiple diagnoses that fall into fibrosis of the lung. You have chronic obstructive pulmonary disease, emphysemas, and chronic bronchitis, as well as cystic fibrosis. And then last, the gray box on the bottom, you can see falls into HCC 114 and 115, regarding Legionnaire's disease and lung abscesses. For some specifics regarding documentation for respiratory conditions, the documentation should always include the status of the condition, whether it's stable or exacerbated, etc., the specificity of the condition, is it bronchitis or is it chronic bronchitis? Is it acute on chronic bronchitis? And then is it COPD or is it emphysema? So really getting to that specificity. And then lastly, the current treatment plan, whether it's managed by a pulmonologist or you're monitoring their medications and increasing the frequency of albuterol, etc. So specifically always include the status, the specificity, and the treatment plan. Pulling in documented complications from specialist notes into your patient's active medical problems list, as well as documenting those conditions within your progress note to put in your assessment and assign on the claim is considered best practice. Documentation solely in a problems list or a past medical history list is not sufficient to show management, evaluation, assessment, or treatment. Again, that CMS acronym MEET, monitor, evaluate, address, treat. A good example of documentation on the right here, decompensated chronic obstructive asthma, continue Spiriva, and refer to pulmonology for an evaluation. that would meet the CMS meet criteria every time for risk adjustment data validation. This is just a table here on the right to show you codes for chronic obstructive pulmonary disease, or COPD as it's commonly referred to. This category includes many codes for specificity. So whether it's COPD, can we get more specific and specify whether it's with a lower respiratory infection or if it's with or without an acute exacerbation. And the same goes for chronic bronchitis. Is it simple or is it mixed? As well as emphysema. Is it interstitial? Is it centrilobular? There are many codes here on the right where you can see we can get real specific with the diagnosis code for each descriptor that you can provide in your documentation versus being unspecified. So talking about COPD documentation and the specificity, it is very important to document and code the specific type and status of COPD that's present at the time of the visit. If it's chronic bronchitis, the documentation needs to state that it's chronic bronchitis. Unspecified and acute bronchitis are not included in the risk adjustment model. So if your patient does have chronic bronchitis and comes in with acute bronchitis, then it would need to be documented as acute on chronic bronchitis. Same goes for COPD. Any exacerbations or lower respiratory infections that are present at the time of the visit should be documented as current because it will impact code assignment. And the same with emphysema. Emphysema is just considered a more specific type of COPD. So if you were to look at an umbrella and the umbrella is named COPD, under that umbrella you have your emphysemas and you have your chronic bronchitis. So just get as specific as you can with the diagnosis terminology in the progress note. Last thing I want to call out attention to here is smoker's cough. So many of you may not realize that smoker's cough actually classifies to J410 simple bronchitis, which is included in the risk adjustment model, but it's very commonly miscoded or misrepresented in your active medical problems list. So if your patient has a true smoker's cough, don't just have a diagnostic statement of cough there, because that would code out to R05, which is not included in the risk adjustment model. But if it's a true smoker's cough and you bring in that descriptor that says smoker's cough, the appropriate code assignment for that is J410, which codes out to simple bronchitis, and that is included in the risk adjustment model. There's also a code also rule that says you should consider adding a Z code to relate to tobacco use or dependence if known. So if you do know that your patient is an everyday smoker or that there once upon a time was a major use of tobacco, then assigning the appropriate Z code may be necessary. Just calling out a little additional information here regarding documenting coexisting COPD conditions. More than one condition documented in the same note truly impacts how the diagnoses are reported. There are includes and excludes notes within the ICD-10 instructions on how to classify these combinations. So, for example, if I have COPD, chronic bronchitis, and emphysema, that's going to code out to J449 for COPD. Or if I have COPD and emphysema, it's going to code out to J43.9 emphysema as it's more specific. And again, you can see these in the table on the right where I call out the actual combination with the ICD-10 code, and then the table on the left is basically the instruction from the ICD-10 manual that gives the coder instructions on how to appropriately code and what's included within each category. So in this case, you see the J44, which is other chronic obstructive pulmonary disease, and what's included in that. Common respiratory coding and documentation opportunities and observations. A lot of times when we perform chart reviews, these are some of the things that we find. Conflicting documentation is the biggest hurdle to overcome. Documentation and coding of an acute exacerbation with a normal physical or normal review of system findings. omitting documented conditions from the claim submission. There's ongoing COPD that's documented throughout the progress note. However, it's omitted from the assessment and it's not included on the claim for submission. Lack of documentation for conditions. There's a conditions merely listed in the assessment with no further documentation in the progress note with that CMS acronym: monitor, evaluate, address, treat, and or the condition is only in the problems list or the past medical history and it's included on the claim for submission, but again, there is no documentation in the progress note to support that. And then lastly, lack of specificity in the code selection. So chronic obstructive asthma is documented throughout the encounter and it's even included in the assessment. However, there's asthma not otherwise specified included on the claim for submission, which is not in the risk adjustment model. So in this case, the appropriate diagnosis for the claim submission would have been chronic obstructive asthma, which is included in the risk adjustment model. But in these examples, we see a lot of times a very unspecified type of asthma going out on the claim, which does not help in regards to accuracy of risk score assignment. Common respiratory coding and documentation opportunities and observations continued. Incorrect use of history of. Per the ICD-10 guidelines, a personal history of is a Z code that explains a patient's past medical condition that no longer exists and is no longer receiving any treatment. So for current conditions, even when they're not presenting any problems, we need to avoid documenting as a history of. So many times we'll see patient has a history of COPD, and that will code out to a Z code that's resolved and gone, when indeed that patient's COPD is lifelong and it still exists. So we need to do everything that we can to ensure that we're not calling an existing condition, an existing diagnosis as history of. It needs to be specified as current. And then calling out the use of slashes in documentation, letting you know that slashes are interpreted as either or. So avoid using slashes when documenting multiple conditions. I know a lot of times when we have patients that have multiple conditions, we like to state in the HPI, patients here for a follow-up of COPD / diabetes / congestive heart failure / neuropathy. And those slashes are really to be interpreted as either or. So do your best to avoid using slashes in your documentation. The takeaway today for respiratory condition coding and documentation: ensure that your documentation is clear and specific. Be sure to document the current status and coexisting diseases, which is very important in respiratory condition coding. Interacting conditions and exacerbations can change coding and sometimes the HCC status of a condition. You see the tables here on the right where I've included the diagnosis descriptor as well as the diagnosis code. But most importantly, something to think about is when you have that patient that's on continuous home oxygen without a more defined diagnosis, ask yourself, is it equivalent to chronic respiratory failure? So you have a patient that's got COPD or emphysema, they're on continuous home oxygen. Does that equate to chronic respiratory failure? What if the oxygen was removed? Would that patient go into respiratory failure? So again, consider further specifying your patient's disease burden if they do have a COPD and or an emphysema or any type of obstructive breathing difficulties, specifically when they're on continuous home oxygen. Is there an additional diagnosis that goes along with that? If that patient were to quit utilizing that home O2, what would happen? Thank you for your time today. We really appreciate all that you do. And just remember, the small changes made today in your clinical documentation can make a huge impact in the future. Thank you.